Greetings, everyone. Step right up to the grand stage of ERMP and Beyond, where each case pulses with the lifeblood of clinical medicine. Prepare to dive into a realm where medical mysteries unfold before your eyes. As we venture together, we'll unravel, scrutinize, and conquer the perplexing riddle that lies ahead. Brace yourselves, as we delve into the vast and complex universe of macrocytic anemias. Let the discovery begin without any delay. A 56-year-old woman presented with lower extremity painful paresthesia, which progressively increased over the last 6 months. Examination revealed pallor and impaired position and vibration sensation. Hemoglobin is 9.2 grams per deciliter, and MCV is 112 femtoliter. What is the most likely cause of her symptoms? A. Iron deficiency. B. Vitamin B12 deficiency. C. Folate deficiency. D. Selenium deficiency. The clinical presentation of this 56-year-old woman with lower extremity painful paresthesia, pallor, and impaired position and vibration sensation, combined with a hemoglobin level of 9.2 grams per deciliter and an MCV of 112 femtoliters, suggests a diagnosis of macrocytic anemia. Macrocytic anemia is characterized by enlarged red blood cells and can be caused by several deficiencies, some of which will be discussed soon in this video. Before that, don't forget to subscribe, like, and put in your comments. Let's answer the case. Option A, iron deficiency, typically presents with microcytic anemia, where the red blood cells are smaller than normal, which is not consistent with the patient's MCV of 112 femtoliters, indicating larger than normal red blood cells. Iron deficiency anemia also usually presents with a low MCV and symptoms such as fatigue, weakness, and pallor, but not typically with neurological symptoms like impaired position and vibration sensation. Option B, vitamin B12 deficiency, is a more likely cause of the patient's symptoms. Vitamin B12 is crucial for proper nerve function and the production of DNA and red blood cells. A deficiency can lead to macrocytic anemia, as seen in the patient's elevated MCV, and can also cause neurological symptoms, including paresthesia and impaired sensation due to the role of vitamin B12 in myelin synthesis and nerve health. The patient's presentation is consistent with the neurological and hematological manifestations of vitamin B12 deficiency. Option C, folate deficiency, can also cause macrocytic anemia and similar hematological findings to vitamin B12 deficiency, as both are involved in DNA synthesis and red blood cell production. However, folate deficiency alone without vitamin B12 deficiency is less likely to cause the neurological symptoms observed in the patient. While folate deficiency could contribute to the elevated MCV, the neurological symptoms suggest that vitamin B12 deficiency is more likely. Option D, selenium deficiency, typically does not present with macrocytic anemia. Selenium is important for various bodily functions, including thyroid hormone metabolism and immune response, but its deficiency is more commonly associated with muscle weakness, fatigue due to hypothyroidism, childhood cardiomyopathy, and possibly infertility, rather than the specific neurological and hematological symptoms seen in this patient. In conclusion, the most likely diagnosis for this case is vitamin B12 deficiency, which explains both the hematological findings of macrocytic anemia and the neurological symptoms of paresthesia and impaired sensation. It is important to confirm the diagnosis with serum vitamin B12 levels and to investigate potential causes of the deficiency, such as pernicious anemia or malabsorption syndromes. Treatment would typically involve vitamin B12 supplementation and management of any underlying conditions contributing to the deficiency. I hope you're all settled in as we continue our journey through the world of hematology. Today, we're diving into the intriguing topic of macrocytic anemias. Now, imagine your body as a high-tech factory, and one of its most vital products is red blood cells. These cells are like the delivery trucks of your bloodstream, carrying precious cargo, oxygen, to every corner of your body. But what happens when these trucks aren't built correctly? That's where macrocytic anemia comes into play. Macrocytic anemia is a bit like a production issue in our factory analogy. It's characterized by a decrease in the concentration of hemoglobin. That's the protein in red blood cells that binds to oxygen. For men, the normal range of hemoglobin is about 130 to 175 grams per liter, and for women, it's slightly lower, at 120 to 155 grams per liter. Falling below these levels? That's when we hit anemia territory, but there's more to it than just hemoglobin levels. The mean corpuscular volume, or MCV, is like the size specification for our red blood cell trucks. Normally, they should be between 82 to 99 femtoliters. Go above 99, and we're dealing with oversized models. That's macrocytic. And just like any good detective story, the plot thickens when we look at the causes of this condition. They're split into two main categories: megaloblastic, which includes deficiencies in vitamin B12 and folate, and non-megaloblastic, which encompasses a broader range of issues. So, why should we care about these oversized red blood cells? Well, they're a sign that something's amiss in our body's factory. It could be a nutritional deficiency or a more complex pathology, but understanding macrocytic anemia is like being a quality control manager. It helps us pinpoint where the production process is going wrong and how we can fix it. You might think anemia is just about feeling tired, but it's so much more. Imagine your body as a high-performance vehicle. Just like a car needs fuel to run, your body needs red blood cells to deliver energy. But what happens when you start running low on this vital fuel? That's anemia. It's like trying to win a race with your gas tank on empty. Let's talk symptoms. Fatigue is the most common sign. It's not just feeling sleepy after a long day. It's a persistent exhaustion that doesn't go away with rest. Then there's weakness, and I'm not talking about skipping gym day. This is a profound loss of muscle strength, making everyday tasks feel like lifting weights. And paresthesia, ever had that pins and needles feeling in your arms or legs after sitting too long? With anemia, that sensation can become a frequent, unwelcome guest. Breathing, it's automatic, right? But for those with anemia, taking a deep breath can feel like running a marathon. This shortness of breath, or dyspnea, can really limit your life's rhythm. And let's not forget the gastrointestinal symphony, nausea and dyspepsia playing tunes nobody wants to hear. Now, weight loss might sound like a dream for some, but in anemia, it's an uninvited change that can signal something's off balance. But anemia isn't just about how you feel, it's also about the signs doctors look for. Ever heard of atrophic glossitis? It's a fancy term for a smooth, glossy tongue, a silent alarm for anemia. Pallor, or pale skin, is like your body's way of saying, hey, I need more red blood cells here. Fever can also join the party, not because anemia loves the heat, but because it might point to an underlying infection. And an enlarged spleen, known as splenomegaly, is like a traffic jam in your body's cleanup system, often a side effect of anemia's underlying causes. Speaking of causes, anemia doesn't just appear out of thin air. It's often a red flag waving, signaling other health conditions lurking beneath the surface. The story of anemia is complex, with each symptom and sign weaving into a larger narrative about your health. In conclusion, anemia's clinical presentation is a tapestry of interrelated symptoms and signs. From the overtired body to the subtle hints of a glossy tongue, these clues are pieces of a puzzle that, when put together, tell the story of your body's quest for balance. Let's speak of megaloblastic anemias. Imagine our body as a complex factory, where red blood cells are the diligent workers keeping everything running smoothly. But what happens when these workers are not quite up to the task? This is the case with megaloblastic anemias, a group of disorders characterized by the presence of megaloblasts. These are immature red cells, unusually large and with oversized nuclei, a direct result of B12 and folate deficiency. Now, why are B12 and folate so crucial, you might ask? They are the master builders of DNA synthesis, the blueprint of life. Without them, our cells can't mature properly, leading to abnormal erythropoiesis. This disturbance in cellular proliferation causes cell degradation right in the bone marrow, leading to anemia, a condition where our body is deprived of enough healthy red blood cells. But the plot thickens when we observe hypersegmented neutrophils. These are neutrophils, a type of white blood cell, with more than 5 nuclear segments. Normally, they're the body's frontline defense, but in this case, they're a sign of trouble, indicating more than just a simple deficiency. However, it's crucial to note that while hypersegmented neutrophils are a hallmark of megaloblastic anemias, they're not exclusively diagnostic. They can also appear in other conditions, such as renal failure, adding a layer of complexity to our diagnosis. In conclusion, megaloblastic anemias are not just about a lack of vitamins. They tell a story of disrupted DNA synthesis and abnormal cell maturation, a reminder of the delicate balance required for our bodies to function optimally. It's a condition marked by the presence of megaloblasts and hypersegmented neutrophils, a sign that our cellular factory needs a better supply of materials to keep producing those vital red blood cell workers. Ladies and gentlemen, now we're diving into a component of cellular mechanics, vitamin B12, also known as cobalamin. This essential nutrient, found abundantly in meats and dairy products, is the cornerstone of DNA synthesis in rapidly proliferating cells. Now, you might wonder, why focus on vitamin B12? Well, despite its presence in common food sources, deficiency can occur, and its impact is significant. It's a condition not commonly seen in the general population, thanks to the vitamin's bacterial synthesis in animal products. However, it's a different story for strict vegans, who may not consume these products, and as a result, miss out on this vital nutrient. As we age, the risk of deficiency slightly increases, yet it remains less prevalent than that of folate. But here's an interesting fact: our body's stores of vitamin B12 can last for years, making immediate deficiency unlikely unless intake is severely restricted. So, what leads to this deficiency? The causes are multifaceted. They range from inadequate dietary intake, particularly among strict vegetarians and vegans, to the insufficient secretion of intrinsic factor, which is essential for absorption. Conditions like pernicious anemia and surgical removal of parts of the stomach can contribute to this. Furthermore, malabsorption issues, such as those seen in Crohn's disease or tropical sprue, and even the failure to release B12 from food due to gastritis or alcohol abuse, play a role. The most common culprit behind vitamin B12 deficiency is pernicious anemia, a condition where the body can't properly absorb this vitamin due to a lack of intrinsic factor. In conclusion, while vitamin B12 deficiency is not a widespread concern, it is a critical issue for certain groups, such as strict vegans and the elderly. The absorption process of this vitamin is a complex dance involving intrinsic factor, and when any step is disrupted, deficiency can ensue. Understanding this can help us prevent and manage such deficiencies more effectively. So, let's see the physiology of vitamin B12 absorption. Imagine vitamin B12 as a distinguished guest traveling through the digestive system with an exclusive VIP pass, escorted by a series of specialized proteins that ensure its safe passage and delivery to its final destination. Our story begins in the bustling environment of the stomach, where vitamin B12 is liberated from its protein companions in food, thanks to the acidic setting. Here, it's swiftly picked up by a protein called haptocorrin, like a shuttle waiting right at the airport gate. This is just the first leg of the journey, as vitamin B12 is then whisked away to the duodenum, where it meets its next escort, the intrinsic factor, a glycoprotein produced with care by the parietal cells of the stomach lining. Now, this is where the plot thickens. The intrinsic factor is not just any carrier, it's the only one with the exclusive pass to get vitamin B12 into the terminal ileum, the VIP lounge of our digestive tract. Here, our nutrient hero is greeted by two sophisticated receptors, hubulin and amnionless, who work in tandem to facilitate a smooth transition across the intestinal border. Once inside the body circulation, vitamin B12 doesn't travel alone, it's handed off to transcobalamin 2, a protein that's like the limousine of the bloodstream, delivering vitamin B12 to various tissues in need. Meanwhile, haptocorrin takes on the role of a private jet, flying vitamin B12 directly to the liver, our body's nutrient hub. In essence, the absorption of vitamin B12 is an intricate dance of release, binding, and transport, involving a cast of molecular characters each with a critical role to play. Understanding this complex ballet is not just an academic exercise, it's key to diagnosing and treating vitamin B12 deficiency. Unthrilled in the clinical manifestations of vitamin B12 deficiency. Imagine feeling constantly tired, no matter how much rest you get, or looking in the mirror to find your skin has lost its healthy glow. These are not just minor inconveniences, they are signs that your body is under distress, specifically from anemia. But it doesn't stop there. The tongue, often forgotten, can become inflamed, swollen, and red, a condition known as glossitis. Now, let's take a journey deeper into the body, to the very nerves that carry our sensations and control our movements. Damage to these nerves, or peripheral neuropathy, can lead to weakness, numbness, and even pain. It's like the body's messaging system is breaking down, and in more severe cases, the spinal cord itself begins to degenerate, affecting movement and sensation in a condition known as subacute combined degeneration of the cord. But the effects of vitamin B12 deficiency are not limited to the physical. Our mental health can suffer too. Depression, personality changes, and memory loss are psychiatric features that can severely impact one's quality of life. It's as if the very essence of who we are starts to fade away. So, what ties all these symptoms together? They are the telltale signs of vitamin B12 deficiency, a silent thief that robs the body of its vitality. Fatigue, pallor, and glossitis are just the beginning. Neurological issues like peripheral neuropathy, subacute degeneration of the spinal cord, and focal demyelination can become part of this complex puzzle. And let's not forget the psychiatric symptoms, depression, personality changes, and memory loss, that can disrupt our lives. The message here is clear: early diagnosis and treatment of vitamin B12 deficiency are paramount. It's not just about preventing anemia, it's about safeguarding our neurological and psychiatric health, preserving our quality of life, and ensuring we can live to our fullest potential. Now, let's see the lab investigation for B12 deficiency, a detective story where the clues are hidden in our blood. That's exactly what happens when we investigate this condition. Firstly, let's take a closer look at our blood. A blood film can reveal a condition known as Megaloblastic Anemia, which is like a red flag waving at us, signaling a potential B12 deficiency. This condition is often accompanied by hypersegmented neutrophils, which are like the emergency lights flashing, indicating something's amiss. Our investigative tools include a range of blood tests. A complete blood count is our starting point, giving us a broad overview. We then zoom in with a blood film, hematinics, lactate dehydrogenase, or the LDH, and liver function tests. These tests help us piece together the puzzle, showing us the reduction in B12 and the development of anemia. Now, let's talk numbers. A profoundly macrocytic anemia with a raised mean corpuscular volume, or MCV, is a telltale sign. Elevated levels of bilirubin and LDH may also join the party, hinting at an increased turnover of abnormal cells in the bone marrow. But when do we sound the alarm? A serum B12 level above 300 picograms per milliliter is our green light, indicating normal levels. However, if we find ourselves in the 200 to 300 picograms per milliliter, we're in the gray area, and further enzymatic testing becomes our best friend for diagnosis. Below 200 picograms per milliliter, that's our red zone, signaling a deficiency. Sometimes, we go deeper, literally, with a bone marrow aspirate. This can show us megaloblastic erythropoiesis and marked erythroid hyperplasia, which are like the hidden clues in our investigation, revealing ineffective erythropoiesis and the development of giant metamyelocytes. But we don't stop there. Our quest to uncover the underlying cause of this deficiency might lead us to perform a Schilling's test, gastroscopy, and serological assessment, which can reveal autoantibodies seen in conditions like pernicious anemia. In conclusion, our lab investigations for vitamin B12 deficiency are like a thrilling expedition, aiming to confirm reduced B12 levels and associated anemia. But the journey doesn't end with diagnosis. We continue, seeking out the underlying cause, guiding us towards the appropriate treatment and ensuring that our body's machine runs smoothly once again. The management of B12 deficiency is not just about replacing what's missing. It's about understanding and addressing the root cause. The cornerstone of treatment is B12 replacement, and the gold standard for this is intramuscular hydroxycobalamin. Picture this, a powerful dose of 1 milligram delivered directly into the muscle, 3 times a week for 2 weeks. This isn't just a quick fix, it's the beginning of a journey to replenishment. Following this intensive phase, we maintain the levels with a 1 milligram dose every 3 months, ensuring a steady supply of this vital nutrient. But wait, there's a twist in the plot. For those who are also facing folate deficiency, the sequence of replacement is crucial. B12 must take the lead, as jumping ahead with folate can lead to dire consequences, such as the subacute degeneration of the spinal cord. It's a delicate dance of nutrients that we must choreograph with precision. In conclusion, my friends, the effective management of vitamin B12 deficiency is akin to a symphony. Each element must come in at the right time, with the right intensity, to create harmony. Timely replacement of B12, particularly through intramuscular hydroxycobalamin, combined with a keen eye on underlying causes, is the melody we aim to play. And let us not forget, in the duet of deficiencies, B12 leads the dance, ensuring that we sidestep potential neurological harm. Now let's talk about a topic that affects millions worldwide yet often flies under the radar: folate deficiency. This stealthy culprit is a leading cause of macrocytic anemia, and it's crucial we understand it. So, what is folate, or vitamin B9? It's a vital player in our body, facilitating amino acid metabolism and the synthesis of our genetic material, DNA and RNA. Despite its abundance in various foods, our bodies lose folate at a staggering rate, up to 20 times faster than vitamin B12. This means a deficiency can sneak up on us much quicker than we might expect. Now, let's zoom in on the epidemiology. Folate deficiency is a global traveler, but it finds its stronghold in regions battling malnutrition. While its exact prevalence is elusive, certain groups are particularly vulnerable: children, expectant mothers, and the elderly. Their bodies are in a state of high demand, making them prime targets for this deficiency. But where does folate come from? It's generously supplied by both flora and fauna, with our daily needs ranging between 100 to 200 micrograms. It's absorbed in the early journey of our digestive tract, specifically the duodenum and jejunum. Our liver hoards a decent stash of folate, yet due to relentless cellular activity and natural shedding of cells, this reserve depletes swiftly, losing about 1 to 2% daily. Hence, a shortage of folate can emerge within mere months, a stark contrast to the years it takes for a vitamin B12 deficiency to manifest. So, what leads to this sneaky shortfall? The culprits are diverse, from simply not eating enough folate-rich foods to conditions that hinder its absorption, like celiac or Crohn's disease. Then there are life stages or illnesses that ramp up the body's demand for folate, and let's not forget about chronic liver disease, which can accelerate its loss. Even certain medications and alcohol abuse can disrupt its balance. It's a common tale, especially among the elderly, who may struggle with adequate intake. And for those with conditions affecting the upper small intestine, the risk of deficiency climbs even higher. Understanding these factors is key to prevention and treatment, ensuring that this essential nutrient doesn't fall short in our diets. What are the clinical features of the folic acid deficiency? Imagine feeling constantly tired, weak, and looking paler than usual. These are some of the telltale signs of this deficiency. But it doesn't stop there. Folate deficiency can also be a silent indicator of other health issues, such as celiac disease, which brings its own set of challenges like gastrointestinal discomfort and malnutrition. So, how do we find out if someone has folate deficiency? Through blood tests. These tests reveal a condition called megaloblastic anemia, characterized by larger than normal red blood cells and a reduced number of healthy cells. The key tests include a full blood count, blood film, and red cell folate levels. Interestingly, red cell folate gives us a more accurate reading than serum folate, as it remains unaffected by short-term dietary changes. But here's where it gets tricky. Folate levels can be influenced by another nutrient, vitamin B12. Sometimes, it's hard to tell them apart. Generally, if vitamin B12 levels are normal, folate deficiency is the likely culprit. However, if B12 levels are low or borderline, further tests, like the Schilling's test, are used to differentiate between the two. In practice, trial with folic acid therapy to see if symptoms are improved is the rule. But, and this is a big but, if there's even a slight chance of vitamin B12 deficiency, both B12 and folate must be supplemented together. Why? Because treating folate deficiency alone when B12 is lacking can lead to severe neurological issues. So, what's the takeaway from our chat today? Folate is essential, and its deficiency can be a window into your overall health. Keep an eye on your nutrient levels. Let's dive into the management aspect. The cornerstone of addressing folate deficiency lies in two key strategies. First, identifying and treating any underlying causes, and second, the administration of supplemental folic acid. For most adults, a once-daily oral dose of 5 mg of folic acid is recommended for a duration of up to 4 months. This regimen is not just a random prescription, but is backed by scientific evidence to replenish your body's folate levels effectively. And here's an interesting fact: these levels can be monitored in primary care, making it a convenient process for patients. Now, let's turn our attention to a very special group, pregnant women. Did you know that folate plays a pivotal role in the early development of the fetus? Indeed, adequate folate supplementation prior to conception and during the first 12 weeks of pregnancy is crucial. We're talking about a mere 400 micrograms to 5 milligrams daily, but this small amount carries immense importance in preventing neural tube defects, a serious birth condition. In conclusion, while folate deficiency might present subtly with symptoms like fatigue and weakness due to anemia, its implications are far-reaching. Diagnosis is straightforward with blood tests, yet the true art lies in the management, which is a delicate balance between treating the cause and supplementing wisely. And let's not forget the special emphasis on protecting our future generations right from the womb with the power of folic acid. So, take this knowledge, cherish the foods that nourish you, and join me next time as we continue to explore the fascinating world of medicine. Thank you for tuning in, and don't forget to like, share, and subscribe. Your likes and comments not only enrich our case discussions, but also help us reach a broader audience through the YouTube algorithm.